Sky PGY1 at Florida Atlantic University Internal Medicine Residency Program, and I'll be presenting a case of Acalculous cholecystitis secondary to an acute on chronic hepatitis C infection. Acute Acalculous cholecystitis, or AAC, accounts for about 10% of cholecystitis cases, and it represents the inflammation of a gallbladder without evidence of gallstones, usually resulting from gallbladder stasis and ischemia, which then causes a local inflammatory response within the wall. The condition is typically associated with critically ill patients, as well as numerous other associated risk factors. There have been a few cases reported of AAC secondary to hepatitis infections. We present a case of a patient with acute on chronic hepatitis C, or HCV, infection leading to acute acalculous cholecystitis. A 27-year-old female with a past medical history of endometriosis, IV drug abuse, anxiety, and untreated hep C presented to the emergency department with fever, chills, nausea, vomiting, and right upper quadrant abdominal pain for 4 days. On admission, her labs were significant for an elevated total bilirubin, direct bilirubin, alkaphosphatase, ALT, and AST noted here. And in the ED, an abdominal ultrasound revealed an enlarged gallbladder with echogenic material, likely sludge. We subsequently obtained an abdominal CT shown in Figure 1, which revealed a normal liver, contracted gallbladder with 9 mm of wall thickening and a common bile duct of 4.6 mm. Her acetaminophen levels, drug screen, autoimmune panel, and portal venous ultrasound ruled out any underlying liver pathology. Her subsequent MRI/MRCP revealed no evidence of choledochal lithiasis, no intra or extrahepatic dilation of the pancreatic bile ductal system, and marked dilation of the wall of the gallbladder the following day. Finally, her HIDA scan failed to visualize the gallbladder, and her hepatitis panel revealed positive HCV antibodies with an RNA viral load of over 100,000. Of note, she was diagnosed in 2018 with hepatitis C and had an undetectable viral load the month prior to her presentation during an elective abdominoplasty. Over the course of her hospital stay, she was managed conservatively with IV fluids and piperacillin and tazobactam. Her lab abnormalities downtrodden, and she was discharged after 6 days. Our discussion focuses on viral hepatitis being a very rare cause of AAC, and the pathophysiology is not fully understood. Imaging can be used to help diagnose a patient with suspicion of AAC, and radiologic criteria have been developed for ultrasound, CT, and HIDA. Gallbladder wall thickening above 4 mm with sludge on ultrasound, the modality of choice, is a typical finding associated with AAC as seen in our patient. Once diagnosed, the treatment of choice is percutaneous cholecystostomy. A case report by Omar et al. Revealed an abdominal ultrasound that had diffuse thickening of the gallbladder wall with laminated hypoechoic appearance, without gallstones and no pericystic fluid collection. In their case report, the HCV RNA PCR conferred a flare up of HCV in their case, similar to ours. Elevation in serum total bilirubin and alkaline phosphatase concentrations are not common in uncomplicated acalculous cholecystitis, since obstruction is limited to the gallbladder, which differs from our case. Previously, cytomegalovirus, Epstein-Barr, HBV, and HAV have been documented as causes of AAC, but HCV is not as common. Although not a common diagnosis in the clinical setting, our case highlights the importance of screening for viral hepatitis when AAC is suspected in the setting of liver function test derangements.